Hello, my name is Bridget Gonzalez. I'm a fourth year PharmD candidate, and today I'll be talking to you about phototherapy. So just talking about what phototherapy is, why we use it, and the risks and benefits of it. What is phototherapy? Phototherapy is going to be those little babies in the NICU that have those blue lights shining on them. They've got their little goggles to protect their eyes. Since it's continuous bright light shining on them, that way they can still get rest and it doesn't potentially hurt their eyes. So it's the best way that we have to treat hyperbilirubinemia, or jaundice, in our neonates. It's the least risky, it's the least invasive way to fix it. So we shine those lights at 460 to 490 nanometers, which is that blue-green spectrum. And we shine that on the baby for some length of time until we've got a desired level of bilirubin. The reason we don't want the bilirubin to stay high is because you can run into neurological development issues. It's actually neurotoxic and can cause apoptosis of neurons and other materials in the brain, which obviously we do not want. So we have to fix the hyperbilirubinemia before baby's allowed to go home. How does phototherapy work? We use that blue-green range of light because that is the spectrum that bilirubin actually absorbs. And when it absorbs that light, it oxidizes the bilirubin, which changes it to biliverdin, dipyrroles, and monopyrroles, which are water-soluble, which means they can then get excreted in the urine and feces, which would lower the serum concentration of bilirubin. The conjugated bilirubin doesn't get reabsorbed in the intestinal mucosa, so it all just goes out. That way we can get rid of the unconjugated bilirubin and overall just lower your serum concentration. When should we use phototherapy? We'll go into a little bit more detail on the next slides with some graphs and things, but generally when you've got a neonate whose total serum bilirubin is greater than 14 milligrams per deciliter, that's when we start running into issues and we need to really get that cleared down. And then if it's greater than 25, or if it's getting close to that level, then we probably need to do exchange transfusion. Absolutely, if it is over 25, we need to do exchange transfusion, which is where we just take some of the baby's blood and replace it with donor blood, just in small increments until we've done basically a full replacement of their blood. That way they do not have all that bilirubin floating around in their system, able to cross that blood-brain barrier and cause brain damage. These babies may or may not also get phototherapy, but they're definitely going to get their blood transfused. And then babies that are at high risk of developing hyperbilirubinemia will probably get phototherapy as well. And we'll go into that on the next couple of slides. How do we evaluate risk of hyperbilirubinemia? We're going to evaluate their total bilirubin based on their age in hours. So you'll notice that the x-axis on this graph is their age in hours, and then the y-axis is either the total serum in milligrams per deciliter or micromoles per liter. The different lines are different gestational ages and risk factors. So a healthier, older baby is going to have a higher threshold for therapy, and then your sicker, younger babies are going to have a much lower threshold because those babies are just generally more sensitive to the effects of hyperbilirubin, and they may or may not be able to clear it on their own anyway. So if the total serum bilirubin is higher than or on the curve, we'll initiate phototherapy before the baby gets to go home, or they may get home therapy. This is just another graph of risk of hyperbilirubinemia. So this is called the BHUTANI nomogram. Babies that are in the low to intermediate risk zone will not necessarily need any kind of hospitalization. They could be managed at home. But if you're in the high intermediate to high risk zone, you're going to need to be hospitalized and start phototherapy. If not, actually do that exchange transfusion. But again, we assess in how old they are, in their hours since birth, and then those serum bilirubin levels. This slide shows some different risk factors for developing hyperbilirubinemia. So if their total serum bilirubin or transcutaneous bilirubin is in that high risk zone, if they've had jaundice in their first 24 hours of life, if mom and baby had different blood types, which we would know by a positive direct Coombs, that would cause some hemolysis of the blood, and therefore we're going to have more bilirubin within the blood. And then if the gestational age is 35 to 36 weeks, if their prior sibling had phototherapy, if they have a cephalohematoma or bruising, that can be another factor. East Asian race, and then exclusive breastfeeding, especially if they're feeding poorly or they've had weight loss. And the reason why breastfeeding is a risk factor over formula feeding is because it's more of a variable amount that baby's going to eat, especially if baby isn't latching well, just isn't breastfeeding very well, and if mom isn't producing enough, then baby's more likely to be dehydrated, which makes it harder to clear the bilirubin, especially since the conjugated bilirubins are water soluble. So if baby's not peeing properly, then the bilirubin's not going out with the urine. Our benefits of phototherapy are that it is very effective in reducing your total bilirubin, reducing your risk of neurologic dysfunction and kernicterus, which is the hyperbilirubinemia encephalopathy. The intervention with phototherapy does reduce your risk of having to undergo exchange transfusion, which is very intensive. It relies a lot on the nurse, several nurses, and it all has to be done by hand. So it is very hard on the staff as well as hard on the baby. And it's non-invasive. We don't really have to have any kind of central lines, any venous access for it. And all it really needs is just a temperature sensor on the baby and just make sure baby's not getting too hot, since the lights are a little bit warm and babies can't regulate their temperatures very well. Phototherapy isn't entirely without risks. It is a very good option. However, things that you can run into rashes. The patient can get a little dehydrated and have hyperthermia since the lights are a little warm. Some lights are better than others. It's less frequent with LEDs because they don't produce nearly as much heat, but it's still possible. And dehydration, just because parents may be afraid to pick baby up and feed them, and just because the elevated temperature can also lead to dehydration. And there is some evidence, it's a very weak association, but there's possibly some evidence that it increases your risk of childhood cancers. The study that I looked at thinks that it's probably more likely because the bilirubin is elevated in patients that receive phototherapy, but they didn't have lab values to truly deduce that. the risk of solid tumors was greater in those that had phototherapy than those that did not. Either way, we should use our phototherapy judiciously, since there is no intervention that is entirely without risk. Obviously, we want to treat hyperbilirubinemia, since we want the baby to have as good of a chance with their brain development as we can possibly give them. But we don't want to just shine lights on them just because we think they're a little bit high of a bilirubin level. In summary, we've got guidelines from the American Academy of Pediatrics on when to use phototherapy. However, these came out in 2004 and have only slightly been updated in 2009, so they are old as far as guidelines go. So just always be on the lookout for something new to come out on those. Phototherapy, while it's very effective, it's not entirely without its risks. So we do want to really think about it before we initiate phototherapy and know when to stop it, which I should have mentioned on another slide, but we stop phototherapy once that bilirubin has come down to around 13, 14. Then we can stop it, and hopefully the baby can manage the bilirubin on their own without lights. And for the most part, if a patient has hyperbilirubinemia, the benefits of phototherapy are going to outweigh the risks. Obviously, a little bit of a rash, some dehydration, things like that are easier to overcome than neuronal damage from bilirubin crossing the blood-brain barrier. But we still need to remember when to stop it and remember when you should actually use it. So we just need to follow those guidelines more strictly for the most part.